Dear friends, welcome to the show, Talk with your Doc. I am Dr. Prashant Tijani, and with us today is Dr. Marlon Hagerty. Dr. Marlon is a radiation oncologist at Thunder Bay Regional Health Science Center. And today we are going to talk about prostate cancer and radiation therapy in prostate cancer. This month of November is the Prostate Cancer Awareness Month. And in a year, there are hundreds and thousands of patients are being diagnosed with the prostate cancer. It is said that 1 in 7 men will get a prostate cancer in their lifetime. And the incidence of prostate cancer is increasing day by day. And there are various treatments available for the prostate cancer, which includes surgery, chemotherapy, radiation therapy. And today, Dr. Marlon Hagerty is going to guide us about role of radiation therapy in prostate cancer. Thank you, Dr. Hagerty, for coming for the show.
No problem. Good to be here.
Thanks. Please tell us about how does the radiation therapy works in the prostate cancer?
Radiation works by basically killing the prostate cancer cells. So when we either focus the radiation from beams coming in through the patient, it focuses right on the prostate, and hopefully we're successful in killing all the prostate cancer cells so it doesn't come back. Also with brachytherapy, the radiation come from the inside of the prostate when we insert radioactive pellets in, and it gives off radiation that way and it kills the prostate cells.
So radiation rays are given from outside or from inside.
Mm-hmm.
So how do you give the radiation from inside?
That's with needles that are put in between the legs of the man, between the scrotum and the anus, through a region of tissue called the perineum. And the long needles are introduced directly into the prostate organ, and either a radioactive pellet can be left behind, pellets distributed all through the prostate gland, or if the needles are hollow and a radioactive pellet just is inserted for a short period of time, it can go through in and out through different needles, and then the needles are taken out and nothing is left behind. So if pellets are left in the man, that's called low dose rate brachytherapy, or LDR. And if there's nothing left behind, that's called HDR brachytherapy, or high dose rate.
Now, who gets the radiation therapy, or who are the patients? Is it stage dependent, like few patients with stage 2 or 3 gets the patient radiation therapy, or every patient with the prostate cancer gets the radiation therapy?
Well, if you're diagnosed with prostate cancer and you're relatively healthy and you are going to live for a long enough period to benefit from the treatment, then essentially that treatment is offered to you if you want it. But we actually recommend, in most cases, if you have low-risk prostate cancer, that is cancer that's not very aggressive, that we actually just watch that instead of treating it, because there are many men that can be watched for many years and they might die of other natural causes besides the prostate cancer. So we really only look to treat prostate cancer if it's more aggressive, and that would be intermediate risk prostate cancer or high risk prostate cancer. And that's based on the profile of what we see when we do the staging with the workup and what the pathology looks like. Of course, if a man is diagnosed with metastatic prostate cancer, which would be incurable, we would still be treating that case as well.
Okay, so not everybody is eligible for the radiation therapy then, is that correct?
Mm-hmm. Yeah, that's right.
And the person or the patient for the radiation therapy are selected by the doctors depending upon the aggressiveness of the tumor, the stage of the tumor, and the age of the patient, is that correct?
Yeah, sometimes age can come into play as well, especially when we're looking at the brachytherapy option. That's a procedure that requires anesthesia. So you wouldn't want to challenge somebody's cardiovascular system. It's a big challenge to go under anesthesia if there's another good option, which is the regular radiation with the external beams. So we'd have to see if the patient was healthy enough to benefit from healthy enough to go through that procedure, and then that they would actually benefit from brachytherapy too.
Is it an alternative to surgery, or it is given after the surgery or before the surgery?
Sometimes, in most cases, actually, it's an alternative. There's a large study that was published just a few years ago called the PROTECT study in the United Kingdom, where it watched thousands of men over time, and did they just get watched, which is called active surveillance for the prostate cancer, or if they're going to get treated, were they going to get radiation and surgery. And so usually if you can cure the cancer and you're going to get treatment, you look at both the surgery and the radiation as an option. Sometimes one isn't possible based on somebody's overall health. If they've already had radiation in the pelvis, you wouldn't want to give another high dose in the same area, for example. So sometimes one is a better option just naturally based on the patient's profile.
So if patient is not eligible for surgery, then they can be treated with radiation therapy. Is that correct?
Hopefully, yeah. There are some cases where neither option is possible, but that would be pretty rare. Usually when somebody is healthy and they have prostate cancer that's aggressive enough to treat, usually we can do one or the other.
Okay. Now, you mentioned about two types of therapy, external beam and internal beam radiation therapy. So how do we select the options? Like which one I should select? Should I go for external beam or internal? What are the advantages of each?
Yeah, so the external beam radiation therapy is generally easy to do. There's no procedures where you could get an infection from. There's no anesthesia to do. And so to get a patient that's maybe elderly or not as strong to go through something more aggressive, the external radiation is usually still well tolerated and quite effective. Now for the brachytherapy option, I would first need to know if they're peeing okay. If they're having a lot of problems getting the pee out, sometimes that can be with compression of the urethra. So if you think of the prostate being my fist, the bladder being on top, and the penis out on front, the channel that the urine travels to go from the bladder to the penis is right through the prostate. So if somebody's prostate is very large, or sometimes the tumor in the prostate can grow quite extensively, sometimes there's a lot of pressure right in the urethra that doesn't allow the urine to pass through. So if that's already a big problem, if we were to put needles into the prostate and do the brachytherapy procedure, that can sometimes cause enough of an inflammation response to make it even difficult for somebody to pee at all. And we would never want that to happen for somebody. So they have to have a good baseline function before we'd feel it's safe to actually do the procedure.
Okay, thank you, Dr. Hagerty. We'll take a short break and we'll continue our discussion.
No
Thank
problem.
you.